it was very different in terms of delivering the baby, making the diagnosis, rushing to the operating room to get the hernia fixed. And also in the late 70s was the first time anyone started to think, well, maybe we need to artificially support diaphragmatic hernia babies in terms of their breathing and their circulation. So it was in the late 70s that ECMO, the heart-lung machine, was first used for diaphragmatic hernia babies. And it was pretty much exclusively used after surgery because you rush them to the operating room, they have a honeymoon period, they're stable for a while, and then suddenly they show signs of instability, and then we put them onto ECMO. And also, in the 70s, we had a limited repertoire of patches to use for these big holes, and we tried not to use synthetic patches if we could, because obviously they're plastic, so they can be infected, they don't last very long, and they don't grow with the child. So, including our own hospital, tried varieties of muscle flaps, but sometimes you just can't get enough muscle in a small baby to patch the big holes. So things like Marlex, Cylon, basically synthetic, they have the texture of like a Brillo pad, so they weren't very good, but those were the only things that we had. So what changed? In the 90s, I think there was a sort of a dawn of a new understanding in terms of diaphragmatic hernia physiology. So it wasn't that the good lung was squished or the heart was squished, that babies were unstable from diaphragmatic hernias. It was because the lung was already not well developed by the time the baby was born on the affected side. And so there was a change in philosophy to supporting the child so that their good lung stays good and the underdeveloped lung is given time to recover, and let's not ventilate the child too much and induce lung damage. So everything it was more tempered, and we didn't rush the babies to the operating room. In fact, it was Dr. Langer actually published a paper in the late 80s saying how it was revolutionary to not do the operation in the first 4 hours and wait for the first 8 hours. Now we can wait days before we actually fix the diaphragmatic hernia. So the timing was really pushed back. And there were some babies that were too sick, and some of them died without ever having been repaired. And that was, nobody could dream of doing that 10 years before that. And also the use of ECMO support, the use of heart-lung machine support for these kids expanded during the 90s. So it wasn't just after they had their repair and were unstable that we put them on ECMO. We started putting them on ECMO once they were born, if they were unstable, or even before they were repaired, before they were unstable, and we would repair them on ECMO. So that expanded the use of ECMO in our patient population, and it was challenging to repair these diaphragmatic hernias on the heart-lung machine because they could bleed. In the 90s was the first time that people actually contemplated, well, let's try to fix this problem before the lung actually gets damaged. And that was the vision of Dr. Harrison, Michael Harrison from San Francisco, who pioneered the field of fetal surgery. It was non-existent prior to this. And his efforts were to try to remedy the underdevelopment of the lung before the child is born, so that when they're born, they don't have the same physiologic problems. Unfortunately, the only randomized trial ever to be conducted for this didn't show benefit because the mortality rates had improved so much for diaphragmatic hernias that it didn't pan out. Now, I think this is an area that's still of interest, and I'll talk a little bit more about that later. So in the 90s, we started wearing Gore-Tex, and suddenly people start going, well, maybe, this is a good thing to use for biosynthetic purposes as well. And so we started using Gore-Tex to patch our large diaphragmatic hernias, and it was nicer than Marlex because it was more durable, more pliable type of synthetic material. It didn't seem to induce as much inflammatory response and scar, so it didn't cause as much of the scar tissue related problems as the previous generation of synthetic materials. So this is This is a picture of one of the diaphragmatic hernias that had to be vortex patched, so you see the white patch stitched in, and typically the vortex can be cut to any size. It's probably not the best thing to put right next to the esophagus and stomach for some of the agenesis, the really large diaphragmatic hernia defects, because it can sometimes cause blockage of the esophagus. So now we're on to the 21st century, and what's changed in diaphragmatic hernia repair? Well, that fetal repair question hasn't really gone away, and although the new approach is not to repair the diaphragmatic hernia per se, but to try to induce lung growth. So this is the work of the group in Belgium led by Jan de Press, who's actually one of the interventional obstetricians there. So the approach now is not to open up the womb, or, bring the fetus out, open the chest, fix the hole. Now it's through a minimal access approach where they put a balloon and block the airway in the baby before they're born to induce lung growth, so that even if there's a hernia there, the lung is not hypoplastic anymore. So this is a way to address the physiology without treating the actual anatomic issue. And there are not many centers that are doing this, and they are trying to be selective with the ones that are most likely to have the worst lung disease to enter into this. And it's controversial because it's not done under the auspices of a clinical trial, so it's not well received everywhere, and because